The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss Pediatric Brain Tumors 101. My name is Jillian Demas. I'm the Senior Program Manager here at the American Brain Tumor Association. I am delighted to introduce our speaker today, Dr. Corey Raffel. Dr. Corey Raffel is a board-certified pediatric neurosurgeon and leads UCSF's Pediatric Neurosurgery Outreach Service at Good Samaritan Hospital in San Jose, California. His current laboratory work focuses on the use of viruses as a way of killing brain tumor cells. Dr. Raffel received his MD and PhD from the University of California, San Diego. In addition, Dr. Raffel has served on the Scientific Advisory Board of the ABTA for many years, for which we're very grateful. Thank you so much for joining us, Dr. Raffel. You may now begin your presentation.
Okay, well, good morning, everybody. It's my pleasure to be able to give a primer on pediatric brain tumors. I'm appreciative of the American Brain Tumor Association for allowing me to do so. Let's go ahead and get started. I'd like to talk a little bit about brain tumors in children in general. I certainly recognize that no parent wants to find out that their child has a brain tumor, and I think that most of the time when I tell families that there's a brain tumor in one of their child, they kind of don't believe me or are confused. And I think that the best solution to this is to try to get information and to get support, and a lot of that is available from the ABTA. Let's talk a little bit about what are the symptoms and signs of brain tumors in children. I'm then going to talk about what kinds of tumors there are and how they're treated, and then I will also talk about what the chance of survival with a good quality of life is for each of these kinds of tumors. When a child has a brain tumor, the most common symptom is headache. Now, children can get headaches that are not related to brain tumors, so the key is to try to differentiate which headaches might mean a brain tumor and which headaches are something else. Headaches in children are especially worrisome if they are associated with other neurologic symptoms. That could be weakness on one side of the body or double vision or some other indication that the brain or spinal cord are not working perfectly. Amongst those symptoms, we also have sleepiness or personality change, sometimes clumsiness of hands or difficulty with walking. Sometimes the heart rate slows a little bit and the blood pressure can go up. I think it's really important to emphasize that children can get headaches that are not associated with a neurologic deficit and still have a brain tumor. And these headaches are worrisome if a child wakes at night with a headache or has a headache when they wake up in the morning. It's especially worrisome if the headache is associated with vomiting. And the most common picture is the child wakes up with a headache in the morning and then throws up and then feels better. Some other things we worry about when we see a child with headache are headaches that worsen when someone lies down or worsens with coughing, laughing, or straining, when the headache is on the back rather than the front of the head, when there's a really distinct onset of the headache. That is to say, the parents will say to me, yes, the headache started 3 weeks ago, and when the headaches have been going on for less than 6 months. Sometimes children will have headaches and then get a different headache that's related to a brain tumor. So if there's a change in pattern or severity of a pre-existing headache syndrome, then that's also a warning sign. And of course, if the headaches get worse over time, we also are worried about the headache. Another symptom of a brain tumor is vomiting, as I mentioned previously, especially when associated with a headache. The vomiting often is worse in the morning, but improves later in the day. And this vomiting is usually a new symptom and sometimes leads to weight loss. In addition, children can have a new onset of epileptic seizures. That is, they have a seizure, and that can be a symptom of a brain tumor. It's especially true if the child never had a seizure before, so we worry about the first seizure. And we worry when the seizure is not associated with a fever, because children sometimes get seizures when they have a high fever. Unfortunately, brain tumors can occur in children of any age. So sometimes very young children who are less than 2 years of age get brain tumors, and these tumors are hard to identify. An infant may show a sign of a brain tumor if they lose previously acquired motor milestones, or their head grows faster than normal, especially if it's been growing normally initially. Sometimes when a child has worrisome signs or symptoms, a physician will look into the child's eyes, and that's because the pressure inside the head is transmitted to the back of the eye, and we can see that pressure in the back of the eye. And this condition is called papilledema. Sometimes you'll hear a physician say, oh, your child has papilledema, and I'd like to get a scan. When we have suspicion that a child might have a brain tumor, we get imaging studies to look at the brain. These days, magnetic resonance, or MR imaging, is the study of choice for looking at the brain. MR scans are best at seeing tumors, and they don't require X-rays, so we like to use the MR scan whenever we can. However, if an MR scanner is not available, a CT scan may be obtained. CT scans are also good at looking at the brain, perhaps not quite as good as MR scans, but still very good. But it's a study that requires X-rays, so the child gets radiated, and we try to avoid that. Let's talk a little bit about the types of tumors that children get. I think it's important to know that brain tumors in children are not common. That is to say that in the United States, there are about 3 cases per 100,000 children every year. So that's not very common. And if we look at the population in the United States, that means there are about 1,500 new cases of brain tumors in the United States. And if we look at over the total span of a child's life from 0 to 15 years, about 1 in 2,700 children will get a brain tumor. Again, not very common. However, of the types of tumors that children get, brain tumors are very common. The only type of tumor that's more common is leukemia. Leukemia is a tumor of the blood, and that means that brain tumors are the most common solid tumor that children get. So now that we've said that the tumors can occur in children, and we've talked about the symptoms and in general, let's talk about specific types of tumors. The first tumor that I'd like to talk about is called medulloblastoma. This is the most common malignant pediatric brain tumor. It accounts for about 20% of the brain tumors that occur in children, and about 40% of the tumors that occur in the back part of the brain that we call the posterior fossa. Usually, children who have a medulloblastoma present with signs and symptoms related to increased pressure inside the head. The reason for this is that the tumor prevents the normal circulation of fluid that's made in the brain. This fluid is made in the brain and then circulates to outside the brain, and this blockage of the fluid causes pressure. We call this hydrocephalus, which means water in the brain. And we call it water in the brain because the fluid-filled spaces inside the brain get bigger. So you may be told that your child has a brain tumor and hydrocephalus. That's what hydrocephalus is. When you have increased pressure inside your head, it makes you have a headache. And in addition, it makes you throw up. That's why headaches and associated vomiting are so common in children with brain tumors. They get pressure inside their head. Other symptoms that occur with medulloblastoma include double vision, balance problems, and loss of coordination. Here is a MR scan of a child that has a medulloblastoma. And you can see, I can draw a circle around so you can see the tumor here sitting in the back part of the brain. Here's a midline cut of the child's head. You can see this MR scan image has just sliced right through the child's head from the nose here to the back of the head. We can see the tumor in the bottom of the back of the brain. The part of the brain right here that the tumor is involved with is called the cerebellum, and the cerebellum is responsible for balance and coordination, and that's why we have problems with those things if a child has a medulloblastoma. When we see a child with medulloblastoma, the first step in treatment is an operation. So that's the first thing that's going to be done. And we have 3 goals when we do an operation for a tumor in the back of the brain. The first goal is we want to find out what type of tumor it is. We want to establish the diagnosis. So we need to take a piece of the tumor out and send it to the pathologist so he can look at it under the microscope and tell us what kind of tumor it is. In children who have hydrocephalus, our second goal is to open up the cerebrospinal fluid circulation pathways. So that the fluid that's made inside the brain can circulate to get outside the brain and be absorbed, and we can get rid of the hydrocephalus. And then, of course, our last goal is to see if we can get as much tumor out as possible, trying to get all the tumor out that we can see. The reason that we try to take out lots of tumor, and hopefully all that we can see, is that there are many studies that suggest that removing most of the tumor may improve the clinical outcome. The surgeon, of course, has to balance that goal of removing all the tumor with the chance of causing a neurologic injury. And for that reason, it's really good to have an experienced surgeon who knows how to walk that line between tumor resection and causing a problem by trying to take out too much. Interestingly, recent research has shown that medulloblastoma is really not one tumor type. There are at least 4 tumor subtypes that occur. These subtypes are defined by the actual genetic events that occur, that is, the mutations that happen that make cells grow in an unrestricted fashion. And each one of the subtypes has different genes involved. So really, even though they look the same under the microscope, they're different tumors. And one of the things that's very different about them is that the subtype of a given tumor really influences the outcome. So today, when someone has a medulloblastoma, studies are done to determine what subtype of the tumor it is, because it lets us have an idea of outcome and also may direct therapy. After the operation, patients with medulloblastoma are treated with radiation therapy, chemotherapy, or both. The exact treatment that a child gets depends on the age of the child at the time that the tumor is discovered, and also on the subtype of the tumor. The reason that treatment varies somewhat is that radiation therapy may have bad effects on the brain that is developing in a child. And there are lots of studies that show if you give radiation to a young child, you get more damage than if you give it to an older child. So we try really hard not to give radiation therapy to children that are less than 3 years of age. Currently, because of this problem with radiation therapy, our trend is to try to decrease the dose of radiation therapy and add chemotherapy to see if we can get similar outcomes. One of the problems that we have with medulloblastoma is that it disseminates in the fluid around the brain. And this is an MR scan that's cutting through the neck of a child from top to bottom. Here's the top and here's the bottom. And this stripe right here is the spinal cord. And you can see this white layer on the outside of the spinal cord. And that's tumor that has spread in the fluid and landed on the spinal cord. We call that cerebrospinal fluid, or CSF dissemination. And CSF dissemination is a bad sign. It's present in about 20% of children when the tumor is discovered. And because it's a bad sign, it leads to the use of the most aggressive therapy that we have. So we've given our therapy now. How do we do in children that have medulloblastoma? Well, currently, using our best available therapy, we have survival rates at 5 years of about 70%. The survival is really determined in large part by the subtype of the tumor. Some of the tumors have better outcomes, and some of the subtypes have worse outcomes. When a child survives from a medulloblastoma, we have to be careful because sometimes they have cognitive deficits. Their brain isn't working quite so well from the radiation therapy. And for this reason, I personally believe that we need new types of therapy that are effective for treating medulloblastoma and completely eliminate the use of radiation therapy. The next tumor I'd like to talk about is called ependymoma. An ependymoma accounts for about 6% of pediatric brain tumors, and about 70% of them occur in the back of the brain in the posterior fossa, the same location that we talked about for medulloblastoma. The ependymoma has signs and symptoms that are very similar to those for medulloblastoma because ependymomas also cause hydrocephalus. Again, that causes increased pressure inside the head, so we get headaches and vomiting. Because of the origin of ependymomas, which is near a vomiting center, sometimes the vomiting is a very prominent feature of an ependymoma. And here is a MR scan showing the ependymoma. This is a similar picture to the last one we saw where we're slicing from the top to the bottom through a child's bottom of the brain and spinal cord. And you can see here's the tumor sitting in the similar location to the medulloblastoma, pushing on the cerebellum here. It's typical for ependymomas to extend down this way into the spinal canal a little bit, which makes us think when we look at a scan that this might be an ependymoma. This is a similar picture of an ependymoma. This is the front and this is the back on this slice. And here's the tumor sitting in the back of the brain, and you can see how it's running out this way and this way a little bit. Those are normal places where cerebrospinal fluid leaves the inside of the brain to get outside the brain, and ependymomas have a tendency to go through those little holes also. Again, a sign that this tumor is an ependymoma and not a medulloblastoma. And then a similar picture that we already looked at showing the top of the tumor here pushing on the cerebellum. Just like for medulloblastoma, when we see a child with a tumor we think is an ependymoma, the first step is an operation. And in this case, we really want to get a radical resection. And the reason for this is because there's no factor that matters more in how a patient with an ependymoma is going to do than the extent of surgical resection. The amount of tumor that's taken out is the most important thing in ependymoma. So we really try hard to take out all the tumor, because if we do so, we have a good chance of that child doing well. The problem is the same problem for ependymomas and medulloblastoma. You want to take all the tumor out, but you have to be very careful not to cause really bad neurologic deficits, to not cause damage to the surrounding brain when you take the tumor out. With ependymomas, after the tumor is taken out, radiation therapy is often recommended. And special types of radiation, sometimes you'll hear people talk about gamma knife therapy or stereotaxic radiotherapy, may be used. And unfortunately, in ependymoma, we really don't have chemotherapy that works very well. We don't have a role for chemotherapy in the treatment of ependymoma. This is a tough tumor for me as a neurosurgeon because I have so much influence on the prognosis, and I really want to take all the tumor out. But the problem with ependymoma is sometimes it goes places where you can cause really terrible problems for the child by doing damage to the surrounding brain. So we really need to be careful about balancing the possibility of causing deficit that's permanent and difficult to live with when we're trying to get a total resection of the tumor. In ependymomas, we do know that patients who get the tumors when they're younger seem to do a little bit worse. and that a tumor that looks aggressive under the microscope is a little harder to treat. The next tumor that I'd like to talk about is astrocytoma. The problem with the name astrocytoma is that it covers a wide range of tumors, and they differ greatly depending on where they're occurring and how aggressive they are. And so the treatment and outcome is very different, even though we call all the tumors astrocytomas. The symptoms and the signs that a child gets from an astrocytoma depends on the location of the tumor. Sometimes the tumors occur in the back of the brain, in the posterior fossa, just like the medulloblastomas and ependymomas. And when that happens, then the symptoms are similar. They cause hydrocephalus, again, making pressure inside the head high, which causes headaches and vomiting. But these tumors can occur elsewhere in the brain, and when they occur elsewhere, they cause deficits related to their location, or sometimes they cause seizures. The astrocytomas in the back part of the brain in the posterior fossa are common tumors, and they're usually of a subtype called Pilocytic. Diffuse astrocytomas, which the World Health Organization, or WHO, some people will talk about the WHO classification of tumors. Diffuse astrocytomas are grade 2 tumors, and they can occur anywhere. And then some astrocytomas are more malignant, and they usually occur in the top parts of the brain, not the back of the brain. This is a picture of a pilocytic astrocytoma on an MR scan. That you can see it's occurring in the back of the brain, again in the cerebellum here. They often have a big cyst, and the tumor is actually just this little thing sitting right here. And I think that the next slide shows that. You can see that this is just fluid, a cyst, but the tumor nodule itself enhances. We've given contrast for this scan, unlike the prior scan, which makes the tumor show up more. So pilocytic astrocytomas, just like the other tumors we've talked about, have a first step for treatment, and that first step is surgery. But this is what I call a surgical disease, and what I mean by that is that if I see a child with a pilocytic astrocytoma and I take all the tumor out, then the chance of the child being cured is very high, and the child will need no additional therapy. The only therapy that's needed is an operation. So when we see a child with a pilocytic astrocytoma, we try to remove all the tumor. Again, we're trying to balance removal of tumor deficit. Fortunately, the location of pilocytic astrocytomas, unlike ependymomas, is such that often we can get all the tumor out without causing a significant neurologic deficit. So when we operate on a pilocytic astrocytoma, after the operation, we get an MR scan to be sure that we've taken all the tumor out. If all the tumor's been removed, then we give no additional treatment, but we'll still get occasional scans to be sure that the tumor's not coming back, although the likelihood that the tumor comes back, if the scans are clean, is small. If we get a scan and we see some tumor still there, then we need to think about, should we go back in and get the rest out, or did we leave that bit of tumor because we thought it was too dangerous to take out? And if that's the case, then we won't do another operation. But when we leave tumor behind, we will get more frequent scans to watch to see if the tumor recurs. These days, we actually have intraoperative MR imaging. What I mean by that is that when I'm doing an operation, I can stop in the middle of the operation and put the patient in the MR scanner in the operating room, so I can check and see if I've got all the tumor out before I finish the operation. And I think that that will help us in getting all the tumor out and not having to take patients back because we've left a tumor behind. Another type of astrocytoma is the diffuse astrocytoma, which you remember I said was a World Health Organization grade 2 tumor. And you can see in this picture here, this area of contrast enhancement of the cerebellum. It's much hazier than we saw with the pilocytic astrocytoma, but it is still in the cerebellum. So just as patients with pilocytic astrocytomas do well when all the tumor is taken out, patients with grade 2 tumors do well if we can take all the tumor out. But often the tumor can't be completely removed because of its location. And then we will most likely recommend chemotherapy and local radiation therapy. If we look at these diffuse astrocytomas that are occurring in the cerebellum in the back part of the brain, even if we see residual tumor, over the next 10 years, only about a third of them will grow. And for this reason, we sometimes just follow with, for symptoms and scans, and we'll reoperate if there's signs of progression. That's especially true for pilocytic astrocytomas. Another type of astrocytoma occurs in the part of the brain called the brainstem. These tumors grow in the brainstem, and you may hear them called brainstem gliomas. They are really astrocytomas, but we use the word glioma, which is more inclusive, includes other types of tumors besides astrocytoma. The thing that's really important about this is that the brainstem is a critical part of the brain. The brainstem is the part of the brain that connects all the brain with all the rest of your body. That means that all the information that your body sends to your brain, and all the information that your brain sends to your body goes through the brainstem. In addition, the brainstem controls the movement of your eyes, it controls swallowing, it controls the movement of the muscles in your face, the movement of muscles in your tongue. It's when we have a tumor in the brainstem, we often see many different types of symptoms because so many things can be affected. Some of the tumors that occur in the brainstem are focal, meaning that when you look at the scan, they look pretty sharply demarcated from the brainstem. And these tumors usually occur in the top of the brainstem, called the midbrain, or the bottom of the brainstem, called the medulla, or even in the medulla and extending into the cervical spinal cord, both outside the brain and the neck. Sometimes these tumors come out of the brainstem and fill up one of the fluid-filled spaces inside the brain, called the fourth ventricle. If we look at all the brainstem tumors that children get, about 30% of them are focal types of tumors. When we see these focal tumors, usually they're pilocytic astrocytomas, or grade 1 tumors, or diffuse astrocytomas, grade 2 tumors, and sometimes another type of tumor called a ganglioglioma. And less often are they higher grade or more malignant tumors. For this reason, we may try to resect these tumors, but because we're working in the brainstem, we have to be very careful about how aggressive we are taking the tumors out, because there's such a high risk of causing a severe neurologic deficit. Sometimes these tumors are treated with chemotherapy or radiation therapy if there is residual tumor left behind. When we see a patient with a focal brainstem tumor, however, we often feel there's no rush to treat the tumor, because often they cause few symptoms, and often the tumors grow very slowly. Sometimes we will do a biopsy just to figure out what type of tumor it is, and then decide whether, based on that, whether we need to do anything at that time. However, if it's a slow-growing tumor not causing much trouble, we may just watch with scans and see if there's tumor growth or if the symptoms progress, which kind of pushes our hands to do something. The other type of tumor that occurs in the brainstem, the other type of astrocytoma, is called a diffuse Pontine astrocytoma, or sometimes you'll hear them called diffuse intrinsic Pontine gliomas, or DIPGs. Again, glioma is just a more inclusive term than astrocytoma. These tumors really are astrocytomas. The characteristics of these tumors is that they are not sharply demarcated from the brain. Rather, they're diffuse. They infiltrate the brain, and they usually occur in the middle of the brainstem, which is called the pons. These tumors are unresectable, and the reason that the surgeon does not play a role in the treatment of these tumors is because they're infiltrated. That means that they're the areas of the tumor that have tumor cells in it, but also have normal tissue in it. And of course, if we take out normal tissue in the brainstem, we cause unacceptable deficits. Sometimes we'll recommend biopsy for these tumors because it lets us characterize the genetic events that are causing the tumor. What mutations have happened in those cells that are causing them to grow in an unrestricted fashion, and that may help us direct therapy. And this is a picture, an MR scan picture showing of what a diffuse tumor looks like, and you can see the tumor's just filling the whole brainstem here in front of the cerebellum, and you can see the edges are kind of hazy because it's diffusely infiltrating the brainstem. So as I said, people sometimes call of this tumor a brainstem glioma, but I think it's an unfortunate term because when we say that, then we're also including the focal lesions, which are very different. The focal lesions account for 30% of these tumors, so the diffuse tumors are more common. They account for about 70% of the tumors. And I don't like to call those focal brainstem tumors brainstem gliomas because of the difference in prognosis. As I already discussed, surgery can't be done for this tumor because it's invading the brainstem. It's often recommended that radiation therapy be given to these patients, and the radiation therapy is effective in the sense that it will improve symptoms, but only transiently. That is to say, the patients will improve, but then the tumor comes back. And we don't really have effective chemotherapy for this kind of tumor at this time. So unfortunately, when a child has a diffuse Pontine astrocytoma, most often they succumb to the disease. And clearly what we need is radical, new effective therapy, so different types of therapy that attack the tumors in different ways. That's one of the reasons we like to do biopsies on these tumors and get molecular characterization. We hope that we can identify drugs that we can use that will attack the specific changes that have happened in the tumor that are allowing it to grow. So in the future, we're hoping that we'll be able to have therapy based on the genetic mechanism that's caused the tumor. That is to say that we can identify specific mutations that have caused genes to be too active or not active at all, and make drugs that will attack that problem. In addition, as was mentioned in the introduction, I'm interested in using viruses to treat these tumors. We're trying to make viruses that will infect the tumor and kill the tumor cells, but will not infect the normal cells. There's anti-angiogenesis therapy that is being investigated, and this is a therapy where we try to prevent the tumor from being able to make new blood vessels. If the tumor can't make blood vessels, then it can't grow. And there are new therapies using immunotherapy and tumor vaccines, where we're trying to get the body's own immune mechanisms to attack the tumor while sparing the rest of the body. So I'll sum up by saying that brain tumors in children are not common, but we must keep in mind that children do get tumors. So if they have headaches or neurologic symptoms or signs, we need to be pretty aware, and that subtle findings may be important. It's you're not going to find out a child has a tumor unless you are looking to see if they have one. And I would say that the outcome for pediatric brain tumors is not as bad as people think when they're told their child has a brain tumor. As I mentioned, for pilocytic astrocytomas, if we can get it all out in an operation, the prognosis is very good. Grade 2 astrocytomas can also have a relatively good prognosis. There are some types of tumors that I didn't talk about because they're rare but do occur in children, such as gangliogliomas, choroid plexus papillomas, and dermoid tumors that all can be treated. And then we did talk about some tumors that are more aggressive, such as medulloblastoma, some ependymomas, and another type of tumor I didn't talk about called malignant germ cell tumors. But even these tumors may have a 70% long-term survival with surgical resection, radiation therapy, and chemotherapy. We do know, however, that irradiation is bad for the developing brain, so currently our research is directed at finding focus therapy based on what is known about the tumor molecular biology for each tumor type. I think that concludes my talk, and I would be happy to answer any questions if there are any.
Thank you so much, Dr. Raffel. That was wonderful. And we do have some questions, but I also want to remind people how to type in some more questions. So if you look at your control panel again, you can type in the question box at the right-hand side of your screen. Type in your question there, and I will ask Dr. Raffel the question. But we'll start with the ones that have already been submitted. You had mentioned, someone asked that there is no chemo for ependymoma, and the question is why not chemo for ependymoma?
Okay, so that's a really good question, and I didn't mean to give the impression that we have not tried chemotherapy for ependymomas. In fact, there are many people that are actively investigating the use of chemotherapy. The point that I was trying to make is that none of the therapies that we use have been effective against the tumor. The tumor just doesn't respond to the chemotherapy. So it's not that we haven't tried, and we continue to try. It's just that at this time we don't have an effective therapy.
Okay, that makes sense. Another person is concerned about their child has a brain tumor. Should they be concerned about their other children, the siblings of the brain tumor? Should they have them tested? Is there any connection between other siblings having a brain tumor then too?
Okay, so that's also a really great question. And while there are inherited conditions that cause brain tumors in children, they're extremely rare. So when I talk to families and they have one child with a brain tumor, it's usually extremely unlikely that another child will have a brain tumor, and I suggest that we not worry about it. Now, there are some conditions that are, as I said, some inherited syndromes that do have brain tumors associated with them, but usually we know about those problems because of other signs that the child has this condition. For example, type 1 neurofibromatosis or tuberous sclerosis are syndromes that children can have that cause brain tumors, but we know that child has it because we can tell because of other things that they have the syndrome. So if a sibling also has the syndrome, we'll know, again, because they have these other signs.
Great. That probably makes some of the parents feel a little bit calmer knowing that they would already know.
Yeah, I think it's very hard not to worry about your other children when you have a child with a brain tumor, but the truth of the matter is the chance that one of your other children has a brain tumor is very, very small.
Yes, wonderful. As a neurosurgeon, can you tell just by looking at a tumor if it's malignant or benign?
So there are many things that we can do before an operation, looking at the scans to make guesses at what kind of tumor we have. And certainly in the operation, we can determine whether the tumor is sharply demarcated. And what I mean by that is that when I'm looking at the tumor, I can take my a little pointer and say, this is tumor, and it stops right here, and this is now brain. And when I see that, I think that it's a tumor that I can take out. Whereas if I sort of see the tumor blurs into the brain, then I worry much more that it's a more aggressive tumor. The bottom line, however, is that the person who tells us what kind of tumor it is the pathologist. So it doesn't matter what the neuroradiologist, the person who's looking at the MR scan, thinks it is, and it doesn't matter what I think it is when I'm operating on it. What matters is what the pathologist sees when he looks at the tumor under the microscope. So it's really important to be patient because I think everybody always wants to know, well, what kind of tumor is it right away? And we won't know what kind of tumor it is for sure until the pathologist tells us what kind of tumor.
Perfect. So that team-based approach is really important.
Absolutely.
Okay. You talked about not wanting to use certain treatment on children until a certain age, which led someone to ask about long-term effects. I know we're getting some advancement with long-term effects, but this person is questioning, like, how would they find out about long-term effects clinics or survivorship clinics? What should they be looking for? Do you know that answer? Or?
Well, I think if I'm understanding the question, someone's asking, why do we think that radiation therapy causes long-term effects?
Mm-hmm.
And that is because, of course, the children who survive their tumors after the radiation therapy, we watch them over time, okay, and we can see that they are not developing cognitively, that the development you expect to see in a child in terms of their learning abilities and what they learn is less. And it's less for a child who has a brain tumor and has had radiation therapy compared to a child who's had brain tumor and has not had radiation therapy. So we're pretty confident that the radiation therapy is the problem. Now, there are people who are trying to see if there's a way that we can give drugs, for example, that will mitigate that effect, that will make it so that we can give the radiation therapy, have an effect on the tumor, but protect the brain. And that's an area of active research.
Wonderful.
If you do have a child who's had a brain tumor and you're wondering what's happening over time, I think that these long-term survivorship clinics are really great.
Oh, good to know. You also were mentioning about certain tumors that definitely were ones that recur. Someone is asking about a different one and recurrence that you hadn't mentioned. Ganglioma, is that one that recurs, and how often after resection would that type recur?
Okay, so I didn't talk about gangliogliomas because they're a rarer tumor. I was trying to focus on just the more common tumors that occur in children. Of course, there are many kinds of tumors that I didn't talk about, and ganglioglioma is one of them. Gangliogliomas depend a little bit on the outcome. It depends a little bit on where they occur. If they're occurring in the temporal lobe and causing seizures, the outcomes are usually very, very good with just surgical resection. If they occur elsewhere in the brain, then often, again, if the entire tumor can be taken out, the long-term prognosis is very good. If the tumor, if there's some residual tumor, then it has to be watched, and decisions have to be made if the tumor does progress. Now, all that's being said, of course, there's a variation in gangliogliomas too. Some look more aggressive under the microscope than others. That's unusual, but they can, and when they do, they are more aggressive, and the chance of recurrence is higher.
Okay. Referring back to, again, unresectable, the diffuse Pontine astrocytoma, the radiation helps, but it comes back. How many times would you then radiate?
Well, we almost always give radiation therapy to children with diffuse Pontine astrocytomas because it makes the kids feel better. It makes their symptoms improve, and it makes them feel better. So we almost always give it. The problem is we know that when we give it, it's going to be what we call palliative, meaning it's going to make the child feel better, but it's not going to alter the outcome in ultimate.
That's a perfect lead-in to the next question. You know, you said you can't treat, but what then do you as a physician do? And as a social worker, I was going to add in, do you have those conversations about palliative care and hospice? And when you mention palliative care, I really appreciate that you're open to that, because that's not always a conversation that all doctors have. So,
well, I think that I think it's really important for me. I have to back off. So I think that doctors have different philosophies on how they approach problems. And my personality and philosophy is that I'm a pretty blunt and pretty honest guy. And I tell the families that from the start. And if they want, you know, bluntness and honesty, they should talk to me. And if they don't, then they have to find somebody else, because I'm going to tell them what I think is true. And so for the diffuse Pontine astrocytomas, I will say that we will offer therapy, but that the chance that the therapy is going to be curative is very, very small. and thus we need to start planning ahead for some of the problems that we might have if the tumors, when the tumor progresses. And your mention of the palliative therapy group and of hospice are just perfectly appropriate in that regard. We use them extensively here.
Okay, great. When do you transfer your patients to adult care? How long do you follow them for?
So that's a big controversy in neurosurgery these days, because the pediatric neurosurgeons have really established themselves as a subspecialty within neurosurgery, and that transfer of care is sometimes difficult. Here at UCSF, the Children's Hospital has a policy of the cutoff is less than 18 years old. But I'm happy to continue to follow patients in my clinic for longer than that. I just have to admit them to the adult side of the hospital if I need to. So I guess it's one of the advantages of being at a place like UCSF, where we have both adult and pediatric facilities available.
Wonderful. And got time for maybe one or two more questions. What about clinical trials? And is it easy for families to enroll their children in clinical trials? Is it difficult?
All right, so that's really a great question. It happens that almost all children in the United States who have a brain tumor are entered into a clinical trial, and that's because they're very strong cooperative clinical trial groups. That means they're groups where a number of children's hospitals participate, so we can get information more quickly because we can get more patients into the trials. The Children's Oncology Group is one of the really big ones in this country that many children are treated under what we call COG, Children's Oncology Group protocols. At UCSF, we have a smaller group that we also participate in. We're a member of COG, but we also participate in the Pacific Pediatric Neuro-Oncology Consortium, also called PNOC, where we're trying to use molecularly directed therapy. We're trying to identify what the changes are in a given tumor and use that to direct our therapy. So yes, almost everyone gets enrolled in a clinical trial. So it's very easy to do.
Oh, that's good.
And it's not hard. The thing that I want to emphasize, though, is that sometimes parents, when they're told about these clinical trials, say, "Oh, you're experimenting on my child," and that's really just not true. When we do a clinical trial, the question that we're asking is, we say, this is the best therapy we have for a tumor. Can we make that therapy better by trying this therapy? And then we compare the two therapies. So it's not that we're saying we're going to see if this works. We're saying we have two therapies. We want to know which one's better. So that's not, so your child's not being experimented upon. And I think that's really important. Now, there are trials where we are asking questions that are more experimental, and we call those phase 1 or phase 2 trials. But you'll be asked if your child can be enrolled in one of those trials, and those types of trials are usually only used when best available conventional therapy has not worked.
Okay. So it's not something that they would have to worry about bringing up. The doctor would most likely...
Oh, no. Almost every child in this country is entered into a study.
And is it something that, do you know if insurance covers it for families?
Oh, yes.
Okay.
Yes, they do.
Okay, so it's not a worry. That's good for families to know.
Yeah.
And I like how you clarified that they are still receiving treatment, because I think that's still a fear that they are not receiving treatment versus they are. So.
Yes, that's correct.
Now we have it on tape, recorded, for everyone to know. And, you know, as you mentioned, especially for something like the diffuse Pontine astrocytoma, if we don't continue to search for the answers through clinical trials, how are we going to find the answers? And
no, it's the only way we advance things.
Right.
Is by comparing treatments and seeing which one's better. And then, of course, until we get 100% cure with no problems afterwards, we're going to keep trying these trials.
Right.
Because what we want to do is cure every child and have them live a normal life afterwards.
Yeah, that would be That would be a perfect world. So
that's right. That's what we want.
Yeah, even to that. All right. Well, thank you so much for answering all the questions. I think we buzzed right through all those, so I think we'll wrap up with some of the conclusion and introducing the next webinars that we have. But thank you so much. I'm sure people really appreciated that all their questions were answered, and your presentation was wonderful. So thank you so much.
All right, obviously my pleasure. Thank you for the opportunity.
Sure. For more information on, you touched on a lot of topics today, a lot of pediatric tumors, clinical trials. You can find more information at our website, which is abta.org. We also have nurses and social workers who can help you navigate these items such as palliative care, such as clinical trials. You can also call us on our care line, which is 800-886-2282. So I'm going to pause just for a moment, and we are going to stop our recording, and then I'm going to tell you about two very exciting upcoming webinars about molecular